All right, we're going to start on Chapter 9. Now, this chapter is for Module 4. It is not for the Module 3 exam that's coming up next week, but I'm having to record early since I'm going to be at a conference, and I wanted you to have that available to you after the exam next week, okay? So just ignore this recording until then. So we're going to talk first about some considerations that as nurses we need to think about as we are caring for our patients in the labor and delivery setting. Of course, we've talked about being sensitive to their different needs and cultures and belief systems, and this is becoming much more prevalent every day in our world. Any woman, any particular group has different needs, and we need to be sensitive to those. For adolescents, being the age they are, their peers are very important to them. Keeping them active in school and other activities is also very important so they can be a part of their peer group. In the past, people in general looked down on young girls that were pregnant. They were not even allowed. When I was in school, they weren't even allowed to attend school at the same time. They had special classes in the afternoons and evenings, so they were very much separated from their peers. Today, girls are allowed to continue school, even though in the general public, even though we may be more accepting of teenage pregnancy, in many ways, we're really not. Our role as the nurse, like in a prenatal clinic, is to find out how is school going. Are they still in school? Are they doing well? What activities are they involved in? Encourage them, of course, to continue in their studies. This is really important. Are they being teased? How are their peers accepting them? Because if they're not being accepted, if they're being teased, or they're being looked down upon, these are the kids that drop out. And dropout rate in teen pregnancy is very high. According to the March of Dimes, only 40% of teenagers who have a child before the age of 18 go on to graduate from high school, compared to 75% of teens from similar social and economic backgrounds who do not give birth until later. So it's a huge discrepancy. For single women, of course, there's issues with adapting to caring for the child alone, especially if there's not a strong support system. How are they going to juggle the care of the child, daycare, and working and providing for their home and food and clothing? She's having to do everything by herself, and this can be very difficult. Some single women are very strong, but I think it also helps that they have that support system to get through this. For the lower socioeconomic families, they may already have difficulty just maintaining and meeting their basic needs, food and clothing. And now with a new baby, what are they going to do? This is even more difficult. If they're not going to breastfeed, they're going to formula feed. Now they have to buy formula diapers. Guys, I bought just a couple of packs of diapers since my grandchild has been born, and it's ridiculous. It was bad when I had babies. It is really expensive now. For multiple births, now there's more than one, okay? Both infants or triplets or quadruplets need the same basic care, okay? Again, juggling the feeding schedules, the sleeping schedules, along with the rest of life can and is very difficult. Many times with multiple births, there may be an increase in cost associated with NICU time if the babies were premature or had other problems. If preterm or preeclampsia and they were in the hospital during their antepartum period. So high healthcare cost can be a huge burden. And then, as we've mentioned many times during this course, culture and how that may affect the woman in labor, and so we need to be sensitive to that. And if you need to go back and review chapter 6, pages 117, I believe, to 119, around there, I would do so. So we've had the baby in chapter 8, okay, both vaginal and cesarean, and now we're going to talk about some postpartum changes. And these are major. It is after that third stage of labor that, of course, the placenta is delivered during the third stage, that there is a decrease in the hormone levels in the blood, including placental hormones, human placenta lactogen, human chorionic gonadotropin, estrogen, and progesterone. With the uterus, the period of returning to normal is called involution, involution. Initially, there is a rapid decrease in the size of the uterus, but over the course of the next 6 weeks, the uterus continues to return to its pre-pregnant state. If it doesn't, this is called sub-involution. The lining of the uterus, what is that called? Remember? The endometrium. Immediately after the placenta is delivered, the endometrium starts shedding those cells that they need to get rid of. Barring any infection or problems, the lining where the placenta was attached is completely healed within 6 to 7 weeks. Just like the endometrium is returning to normal, so is the size of the uterus. For those of you who have already done your OB rotations, we measure what the fundal height in relation to the umbilicus. The changing in the size of the fundal height averages about 1 centimeter a day. So by 10 days postpartum, the uterus should not be palpable. We also know from previous lectures, or those that have been on clinical, what organ can interfere with the uterus clamping down to minimize bleeding? The bladder. So if the bladder is full, it can cause the uterus not to firm up, and it will continue to bleed. Okay? You do need to review nursing assessment on page 205. I believe that's table 9.1. And you also need to review figure 9-2. After the birth of the fetus, the baby, and the placenta, moms may and will experience after pains. That's that uterus contracting to help it firm up and get back to its normal size. These are intermittent contractions of the uterus to help minimize the chance of heavy bleeding. They typically are stronger with multigravidas. Breastfeeding may also increase the discomfort, but in turn it also decreases the amount of bleeding. When breastfeeding, remember what hormone is released to help the uterus contract? Oxytocin. Okay? It is secreted from the posterior pituitary during breastfeeding. Okay? It does not produce the breast milk, but it releases the breast milk. It releases a hormone to help the breast milk let down and the baby to be able to receive it. Okay? But that same hormone, oxytocin, also helps that uterus to contract so mom doesn't bleed. Lochia. This, of course, is the bloody vaginal discharge after birth. It's composed of endometrial tissue, blood, and lymph tissue. So lochia rubra is the way we describe and document the bleeding for those usually that last about the first 3 days after delivery, and it's bright red in color. After about 3 days, up to about day 10, it's more pinkish in color and mucousy, and this is called lochia serosa. After day 10 to day 21, it's called lochia alba, and it's described as either no color or maybe a white mucousy discharge. The lochia should never be foul smelling. It may have a menstrual type odor, and that's normal. When we're assessing the color and the amount of lochia, we also are checking for the firmness of the uterus. We're checking for any passage of clots from the vagina and assessing the amount of bleeding mom is having. We describe it as scant, light, moderate, large, or heavy. On page 202 in your book, there's a picture of sanitary pads showing how we estimate these amounts. Now, one thing we always want to be aware of and make moms aware of, if they've been laying in bed for several hours and not moving around, we've talked about this in clinical, and I hope you remember, how the blood may pool in that lower vagina. And when it pools, it can clot. So initially when we're massaging that uterus, or maybe when mom stands up the first time, it's not unusual to have some clots pass or some bleeding to come out. That's very normal, but they should only be small clots, about a nickel size or smaller. But it's when they're soaking a pad every hour or more often, they're passing clots larger than a quarter to $half size, that we need to be concerned. And especially if while we're massaging they continue to bleed, okay, and they continue to pass clots. With C-sections, they tend to have a little less bleeding. Not always. Everyone's different. I apologize. Somebody knocked on my door. So we were talking about moms getting up for the first time, or maybe this is, after they've been in bed for a while, or we're massaging their uterus and they're passing some clots and blood. Again, small amount, small to moderate is not unusual, but the uterus should firm up and the bleeding should slow down. Clots should not be really any bigger than about a nickel size. Anything quarter to $half size, we need to be concerned about. Now, if the clots stop after we express them, the bleeding slows down, we don't need to be real concerned, except it's just to continue to monitor them real closely. With C-sections, bleeding is not always as heavy because at the time of the surgery, the physician actually takes a lap sponge and wipes kind of cleans the inside of the uterus to hopefully minimize the chance of a lot of extra bleeding and clots forming. So your nursing care postpartum are fundal checks, medications for bleeding if indicating. Of course, when you're doing those fundal checks, you're assessing for blood, the amount of blood, and any clots, and the size of the clots. If they are bleeding significantly, we're going to give medications that are prescribed. And Pitocin is one that we're going to give in their IV fluids right after delivery to hopefully minimize the bleeding and clot formation and to keep that uterus nice and firm. Provide analgesics for pain. Provide patient education about reporting any amount of bleeding, foul odor, a change in the lochia color and amount. And an example I want to give here is, let's say mom has gone home and it's about 14 days postpartum and her lochia has changed to lochia alba, which is kind of a white mucousy discharge, okay? And all of a sudden it becomes lochia rubra. She needs to report this. Or if she starts passing clots, she needs to report this. Okay? Soon after the delivery, the muscle tone of the cervix is actually regained. Once someone has dilated and delivered vaginally, the cervix never really completely closes as tight. As far as healing, though, the cervix may have some edema from pushing, and just sheer trauma from the delivery. It may have, there are times that lacerations can occur. And with a tear or laceration to the cervix, you're going to have bright red bleeding from those sites. If you think about any type of cut and how cuts and tears bleed, that's what it would happen. With our discussion about childbirth, I hope you remember or understand how much stretching the vagina actually goes through for the fetus to pass through the pelvis and the birth canal. And because of that, the ruga, which are the multiple vaginal folds in the vagina, actually disappear as the baby is descending. That vagina is stretching, and they actually disappear during the delivery. So it is around 3 weeks that the ruga, 3 weeks postpartum, that the rugae returns, and it is around 6 weeks that the vagina that has returned to its pre-pregnant shape, but it never actually is the same size again. Intercourse, the general rule when bleeding stops, and if mom has had an episiotomy or laceration, we want that to be healed before she resumes sexual intercourse. The biggest concern with intercourse postpartum is the natural lubrication from the different glands in the vagina do not always return until about 6 weeks, and sometimes even longer for breastfeeding moms. So intercourse may be uncomfortable. So education regarding using water-soluble gels may help with some of that discomfort. With the perineum, initially with any amount of trauma during a vaginal birth, you want to look at redness, tenderness, bruising. If they've had an episiotomy or lacerations, if they have hemorrhoids and how much worse they are, if they are they causing significant amount of pain? These women need to be on stool softeners, using sitz baths, and then even tucks, Tucks, which are little medicated pads. It has to be a prescription or prescribed by the doctor that they place around their rectal or anus to help soothe and decrease the swelling of the hemorrhoids. An acronym called REEDA, R-E-E-D-A, stands for redness, edema, ecchymosis, discharge, approximation. And this is the acronym you need to use when you're assessing the perineum. Nursing care, of course, comfort and hygiene. Very important. After every urination and every bowel movement, they need to be rinsing the perineal area off with warm water with a spray bottle. Then pat dry or air dry. Sometimes if it's a significant laceration or episiotomy, doctor may prescribe some topical medications such as Epifoam or Dermoplast. I've already mentioned tucks, or even sitz baths to help with the discomfort. But in the first 12 to 24 hours, we're going to use ice packs to help with comfort and to decrease swelling. After 24 hours, we're going to switch over to warm packs and sitz baths. So I believe around 203, 204, and 205, it talks about fundal checks, care of the perineum, and perineal care with sitz baths. So you do need to review those. Continuing on with various postpartum changes. Initially, the first couple of days, the breasts are full but soft. It is around the third day that they start becoming firmer and more lumpy. This is because blood flow is increasing and the milk production is beginning. You've heard the term engorgement. This can happen in both breast and bottle feeding mothers. With engorgement, the breasts take on the characteristics of being hard, nipples are erect, and this can be very uncomfortable. Moms, they'll describe their chest being very heavy or feel like something's sitting on them. They need to wear a bra, You can't forget that. No matter if they're breastfeeding or bottle feeding, they need to wear a bra. This will help with that discomfort. And with the engorgement, this can be very difficult for the baby to latch on initially because the nipple is not as, it may be erect, but because of the swollen breast tissue all around it, the baby doesn't have as much tissue to latch on to. Ovulation, with the fall in the placental estrogen and progesterone levels, there's an increase in follicular stimulating hormone. If you don't remember what that is, we need to go back to that first module and review fertilization and the menstrual cycle. Typically, menstrual cycles return around 6 to 8 weeks. With breastfeeding, they may not return, or they may be more irregular. Does this mean, though, that they're not ovulating? Not always, okay? Many physicians will still recommend a low-dose oral contraceptive to hopefully prevent mom from ovulating. So part of your education of mom is that ovulation still may occur with or without a period. We talked early on in the semester about how young girls may not ever have had a period before they get pregnant. And it's because they ovulated. They had sex before they ever had their first period, and therefore they got pregnant. Same thing can happen postpartum. Okay? So we need to educate mom that pregnancy is very possible. So our nursing care, we're going to be checking the consistency, the size, and the shape, and the symmetry of the breast. Inspect for redness and cracking, painful feeding, flat or inverted nipples, supportive bra or elastic binder if they're not going to be breastfeeding and they don't want to wear a bra. Non-nursing moms, we want to, of course, avoid stimulation because stimulating the nipples or the breast causes the release of that oxytocin, which stimulates lactation. With hygiene, just washing with plain water, avoiding soaps because they can be very drying. All right, going on, cardiovascular changes postpartum. Remember, with pregnancy, there is approximately 50% increase in blood volume. Normal blood loss with a vaginal delivery is around 500 milliliters, and with a C-section, 1,000 milliliters. Even with this blood loss during delivery, there is still an increase volume due to the fact that the blood that was going to the uterus and placenta is now being diverted back to the main circulation. So there's a shift of fluid that was in the tissues and now it's shifting back into the circulation. What you need to understand with this is with the increase in volume back in the circulatory system, there's also an increase in stroke volume. So what you're going to see in the mother's heart rate is bradycardia. Over the next few days and weeks, this returns to normal, and mom is diuresing. Also maybe have spells of diaphoresis where they're sweating profusely, and this is their way of getting rid of that extra volume. Coagulation during pregnancy and postpartum blood clotting factors are typically higher, and we want them to be so mom doesn't hemorrhage, right? But this does not necessarily cause an increase in breaking down of deep vein thrombosis, okay? So we want, she is much more prone to blood clotting, okay? Like in the lower extremity. So we want to be aware of this. We want to assess for pain in their calves. We want to assess for asymmetrical swelling in their lower extremities. We also want to assess for pulmonary embolus. They may experience tachypnea or dyspnea, and we need to provide immediate intervention. Blood values. It is very difficult to interpret blood values right after delivery because with all the trauma and inflammation that's occurring, and also the dilution of the blood because of all the fluid shift back into the circulation, the H&H, or hematocrit hemoglobin, may be lower than normal. But this usually does return around 6 to 8 weeks. White blood cells are elevated, anywhere from 12 to 20,000. So you need to know your normal white blood count, okay? Because just because it's slightly elevated those first few days and weeks postpartum does not mean mom necessarily has an infection, okay? This is a response to the inflammation, the pain, the stress that mom has been under. But usually the white blood count does return around day 12. Chills, not unusual, okay, especially right after delivery. It's almost like a tremor. This is a vasomotor response with the release of epinephrine during delivery. Mom may say, I don't feel cold. I'm just shaking, okay? Usually goes away in 20, 30 minutes, maybe up to an hour. Now, after 24 hours of delivery, if they have fever of 100.4 or greater, or chills, we need to be concerned about an infection. But what I just said a few minutes ago, okay, about their WBC may be elevated, but that's not necessarily indicative of an infection if it's between 12 to 20,000, okay? Also, another thing to think about, what happens to someone's heart rate when they have a temperature? It goes up, right? They become tachycardic, right? But in a postpartum mom, they're supposed to be bradycardic. So if you see tachycardia in a mom, you need to be looking out for an elevated temperature and other signs and symptoms of infection. Orthostatic blood pressure. Not unusual for this to happen with the blood loss they have had or have experienced, and also the shift in the fluid shift in the maternal circulation. So the first time or two, we need to ask them to sit on the side of the bed, take some deep breaths, kind of get their bearings. Maybe having we need to be by their side to help them that first time or two before they just stand up because they are more prone to orthostatic hypotension. Nursing care, vital signs initially are every 15 minutes for 1 hour, then every 30 minutes for 1 hour, and then every hour for up to 4 to 8 hours, depending on hospital protocol. A temperature of 38 degrees Celsius and 100.4 degrees Fahrenheit after 24 hours should be a concern. Remember, with an increase in volume and stroke volume, mom is going to be bradycardic. So if the pulse is tachycardic, could mean an infection. Diaphoresis and diuresis is normal. We want to assess for thrombosis in the lower extremities, redness, tenderness, pain. Okay? With the urinary system, this usually returns to normal in about a month. Remember, a full bladder can lead or contribute to postpartum hemorrhage. We want mom to drink plenty of fluid, to flush out her kidneys, hopefully to avoid infection, and help keep her hydrated, which also helps with her possible constipation. Make sure she understands to empty her bladder frequently and report any decrease in amount or pain with urination or frequency. You need to be assessing for distension. It may be full and she doesn't feel like it is, especially if the epidural has not worn off yet. We always want to measure the first 3 voids after every delivery or after a catheter has been removed. We want to hopefully that she's voiding at least 100 mils each time. After that, we want to monitor her voiding at least once a shift, if not more often. If she's having trouble starting her urination, of course, provide privacy. Don't rush her. Run some water, hand in the warm water, peri bottle. Rinsing her peri area off while she's trying to urinate will help. GI system, with the decrease in progesterone, the GI will return to normal. The biggest problem that occurs, of course, we've talked about multiple times, is constipation. Some of the medications that she may have received, and also pain medication, slows the peristalsis. So fluids, fiber, ambulation. Abdominal muscles, remember those have been stretched immensely during pregnancy, and while they're still not toned up yet, believe it or not, our abdominal muscles really help us defecate. And if we don't have a lot of strength in those abdominal muscles, that prevents us from bearing down. Also, any soreness or swelling or hemorrhoids is going to prevent us from bearing down. So all the things that we teach our patients to do to prevent constipation, we want to do that. And then, of course, providing stool softeners if they are prescribed. The skin, we talked about skin changes early on in pregnancy. The hyperpigmentation, striae or the stretch marks, or the linea nigra, which is that linear line, dark line up and down the abdomen. These do disappear over in the next couple of weeks, and the stretch marks eventually fade. With musculoskeletal, because the abdominal wall has been stretched, the belly feels kind of doughy. This can be very disturbing to moms. They don't think it'll ever go away. We need to reassure them, though. It takes time and it takes exercise. A condition called diastasis recti is when the longitudinal abdominal muscles are separated during pregnancy. Actually, it's like a hernia. There's a weakness in the muscle. This can last many weeks and may contribute to increased problems with constipation. Their center of gravity also returns to normal. So exercises we want to teach them is some abdominal tightening, Kegels, head lift, pelvic tilts are all really good to help tone up those muscles. Immune system. Remember when this is given? When mom is Rh negative. It's given around 28 to 30 weeks pregnant if mom is Rh negative. Then after delivery, if baby is positive, we're going to give the RhoGAM within 72 hours after delivery. And this prevents the Rh positive cells to be synthesized when they enter mom's bloodstream. But it's only given to mom, and of course we want to carefully document this. With the immune system, of course, we want to provide any type of immunizations mom might need, like Tdap if she hasn't received that before or during pregnancy. Rubella, if she was non-immune before pregnancy, we want to immunize her before she goes home. If she is immune, a titer of 1 to 8 is considered immune. But if she's not, again, we want to give this before she goes home. We do not want her to get pregnant, so part of our education is that she needs to be on either refrain from intercourse or be on birth control at least for a month before she gets pregnant after the rubella vaccine. And it does not affect the breastfeeding. We will need to be careful in giving her the MMR if she is immunocompromised or if she has sensitivities to neomycin, eggs, or gelatin. Many times, unless a C-section was planned, then it's an emergency or a situation where mom did not progress in labor. And we call that failure to progress, and that's typically caused because of cephalopelvic disproportion. Remember where you've heard that before. And I got to thinking a couple of years ago, failure to progress. We're doing your C-section, Mom, because you failed to progress. What do you think that might make moms feel like? They're already stressing out. They're tired. They're exhausted. They're worried. They didn't want a C-section. They've never had surgery before, and they're very, very scared. All right? But that is many times the reasons why C-sections are done. Much of the care for mom who's had a C-section is going to be very similar to for a vaginal delivery. The bubble He assessment is one of your primary focus. Of course, you're going to listen to heart and lungs. You're going to listen to bowels. You're going to assess that abdominal dressing to make sure it's clean, dry, and intact. Once the dressing is removed, we're going to assess that incision to make sure that it's not red and swollen, that it's approximated. What is it approximated with? If they've continued with IV fluids, what does their IV site look like? What is type of fluids, and what is the rate? If they have a Foley catheter, what size, what color of the urine, and what is the output? With any abdominal surgery, respiratory is very important. We want them to turn, cough, deep breathe every 2 hours. Use incentive spirometry. We need to auscultate their lungs at least every shift. We want to listen for crackles, wheezes. When they're coughing, we want to show them how to splint their abdomen with a pillow to help the discomfort. And we want them to ambulate as quickly and as soon as possible, again, to help move the fluids that are dumping back into their circulatory system, and also to prevent respiratory infections. With ambulation, of course, that's going to hopefully decrease the risk for thrombophlebitis. But if they're in bed and they need to stay in bed for other reasons, simple leg exercises, sequential compression stockings is very important. Pain management is also important, measuring that pain scale, and that would be even for a vaginal delivery. Where is the pain? The quality. Intermittent, constant, stabbing, jabbing, aching. What does it feel like? What relieves it? Providing the narcotic analgesics, whether it's oral or IV medication or PCA. It needs to be given, and it's better to be given on schedule than to wait till mom is hurting really, really bad, because it's going to take a lot more medication to get her under control. So we've talked a lot about the physical changes taking place after delivery, but there's also a lot of emotional changes as well. Mothers, their hormonal, they have hormonal changes, body image changes, and a lot of thoughts and feelings are going through. With the fluctuating hormones, these have an effect on that mom's psyche. One moment they may be very excited and elated, and the next they may be crying. The postpartum period is a time of adjustment. In your book, Rubin, R-U-B-I-N, describes 3 phases, as I believe on page 212: taking in, taking hold, and letting go. It's not unusual for new moms to experience what we call the postpartum blues or the baby blues. Part of our discharge teaching is describing these signs and symptoms to mom and helping her understand that feeling down or feeling out of sorts is not unusual, but when these feelings persist, of unhappiness, not eating, crying, irritable, thoughts of suicide, of hurting the baby, that's severe, and and that's not expected. And they need to call in and be seen by and evaluated by a professional. Fatigue is a big issue, and that can, definitely contribute to feeling just kind of down and out. So when baby sleeps, encourage moms to sleep. Don't do the wash. That is when they need to be resting. When baby wakes up, For frequent feedings, maybe someone else, a support system. The father, significant other, grandmas, aunts, uncles can help with those. Moms need to get the rest they need, but many times moms want to be totally involved, and that's good. But they also need to understand the importance. Mild depression usually peaks around day 5. Postpartum depression, and we're going to talk more about this later. Typically, is after that. It's after around day 10, and like I said, it's that persistence of unhappiness and not eating and crying and those type of feelings. Fathers also are very engrossed in their new baby. Oh, one more thing about mom. You do need to go back and review taking in, taking hold, and letting go, and understanding how these relate to mom and how you intervene as a nurse. With fathers, like I said, they become very engrossed with their babies. They're very excited. They also have 4 phases of adjustment, having expectations and personal intentions. They expect themselves to be good fathers. They want to be a good father, okay? They start confronting reality and realizing, wow, this is huge. There's a lot of responsibility here. And may be frustrated because, they're trying to help mom feel better, and they're trying to help baby, and trying to, cook, trying to wash the dishes, clean the bathroom, do all, and just the frustration of trying to get organized and feeling like they can be helpful. To creating one's own personal father's role. What do they want to be? What kind of role do they want to be for their child? And then, of course, reaping the rewards of fatherhood. As that child grows and recognizes that father and acknowledges him as someone who's significant in their life. And this happens with moms too, just at different stages and phases. Siblings. Of course, this can be a huge adjustment. Depending on the age of the child, their feelings about this new baby may be shown through regression and anger, such as a toddler. Okay. Preschool may be more interested in this baby. Older children actually enjoy caring for the baby and may be very curious. Grandparents, well, I don't think I have to say much about that. But their involvement, of course, may be based where they live, their location, their culture, and their personal feelings and their relationship with their child. Grieving and parents, of course, listening and supporting them. Therapeutic communication. Open-ended questions. Reflection. Allowing them that opportunity to share what they're feeling. We need to encourage them. We need to encourage them to share their thoughts and feelings. If death is not expected, it's not uncommon for the usual reactions to occur: the shock, the anger, denial, the guilt, the sadness, and then eventually resolution. It can be tough, honestly, guys. I've been there, and maybe some of you have too. I hope not. I think, I always say it's not what we say, it's what we do. And it's not necessarily the words we say, it's the words we don't say. And so literally just sitting quietly with that family and allowing them to speak when they're ready to speak, allowing them to cry, allowing yourself to cry if you need to, is important, and providing the support they need. All right, so now we're skipping over in that chapter a little bit over to breastfeeding and bottle feeding. I know breastfeeding is a very personal choice, and in this chapter, and I know many of you promote breastfeeding. I promote breastfeeding because it is a very good way to feed our babies, but again, it is a personal decision. And no one should ever be looked down upon or ridiculed or made to feel inferior or less of a mother because they have made those decisions. I think, loving our child is probably the number one priority. And how we love our children is going to be different from one person to another. And it's not only food feeding our child is not the only way we love them. Okay? So, again, I think in choosing whether it's going to be breastfeeding or bottle feeding, I think moms need the education. I think that's really, really important. Okay? There's lots of reasons women choose formula. Life, commitments, lack of support their mothers may not have. I know, when my mother had us, breastfeeding was not heard of. Also, she felt like in the position she was in as a pastor's wife and people coming over to the house all the time, she couldn't just stop and breastfeed just any time. But part of that was her generation and her thought process. Now, she didn't care what we did, but she made it very well known she would have never done it. So it was kind of one of those things, okay, Mom, we understand, but this is something we needed to do for us and our babies. Okay? So our job as nurses is to give them the emotional support they need to be successful. Give them the tools to be successful if this is something moms choose. Hold on. All right, let's talk a little bit about the advantages and disadvantages of breastfeeding. Of course, full range of nutrients. Breast milk is typically easier to digest for infants. It doesn't cause allergies. It provides natural immunity. The precursor milk, or the colostrum, provides a particularly high amount of antibodies, which is important for the baby. It promotes defecation or elimination of meconium stool. The sucking on the breast also helps promote oral development. It's convenient and economical. So for maybe that single mom or that mom that does not have an income, it's lower socioeconomic, if we can give them the right tools and help them to be successful, this will be cheaper, less expensive for her. Okay? Now she still needs to eat well so she stays healthy and she can, produce the right amount of milk that the baby needs, but it is less expensive than buying formula. It also promotes brain development, which is huge. For moms, a benefit is typically it uses up our additional or extra fat stores that we've developed during pregnancy and helps us lose weight. Some of the contraindications would be certain medications moms are on. Chemotherapy drugs, those things would definitely be a contraindication. If the baby has true galactosemia, breastfeeding is contraindicated. Active tuberculosis with HIV, active herpes lesions on the breast, and then breast cancer actually can become worse with the hormonal changes. So, excuse me. With the physiology, we have two hormones that you need to know about, prolactin and oxytocin. We've already talked about oxytocin coming from the posterior pituitary gland, which actually helps the milk to let down or to deliver it to the baby through the duct system of the nipple. Prolactin comes from the anterior pituitary, and this produces the breast milk. Okay, so you need to know the differences between those. It's the sucking of the breast that I mentioned earlier that actually stimulates that hormone oxytocin to be released from the pituitary that helps the letdown of the milk. And it's, again, the prolactin secretion will increase, as the milk is being removed from the breast, okay, because it's being stimulated. So it's very unlikely in most situations, if mom is nursing appropriately and nursing often enough, that she will not have enough milk for her baby. Okay, there are those rare circumstances, and I'm not going to say it doesn't happen, but very little, it's not very often that that occurs. The more the baby is put to the breast and sucking correctly, the more the prolactin is being produced and producing that milk, or prolactin is being secreted and producing more breast milk, and that oxytocin is being released and causing the letdown effect of the milk. Foremilk is the first milk the infant comes in contact with, and then the hind milk is the later milk, which has the higher fat content. So that's the reason you want the baby nursing for more than just 2 or 3 minutes, because they're only getting that foremilk. Okay, it's that hind milk that has the fat and the nutrition they need. There are 3 phases of milk production: colostrum, which we've already mentioned, transitional milk, which usually comes in around 7 to 10 days, and then the mature milk, which comes in about 14 days. So we want to promote bonding, okay? It also helps maintain infant temperature by that skin-to-skin contact. Stimulating that oxytocin helps mom not to bleed as much, hopefully. So those are ways that breastfeeding assists moms. On page 224, there's a table there on teaching new mothers how to breastfeed. I think it's a great little chart that kind of explains and gives rationales of why we do the things we do. And so I want you to review that and know that. But the focus that you need to pay attention to is early breastfeeding, early on. Those first few hours is very, very important. One, it helps mom to get in position, to help correct any incorrect positioning of the infant. It starts stimulating the production and the release of that breast milk. And again, it gives that reassurance and confidence in the mother early on. Lots of different positions your book describes. And on page 225, it gives some essential techniques in breastfeeding, and I think those are some great tips to review and to understand. With formula, we need to understand there's different types of formula. Similac Enfamil is a form of cow's milk. If there are any sensitivities, though, to cow's milk, family history, babies may be started on soy products. There are many formulas out there, though, for babies that have special needs, such as preterms, and babies that have a positive PKU, and we'll talk more about some of those situations later. There are ready-to-feed formulas. There's concentrate formulas. There's powdered formulas that you have to mix. All of them have a different purpose. I always think the ready-to-feed are great for traveling. That way you don't have to worry about water and contamination and sterile bottles or clean bottles. The one thing that is very, very important is education. Moms need to know how to read labels and how to mix these formulas. The concentrated is exactly what it says. It's concentrated. And, I've heard of babies coming in with what we call failure to thrive. They're not gaining weight and they're not growing. Lots of different reasons for failure to thrive. But one incident I heard or I saw was these parents, they were talking to the parents, asking questions. What are they eating? How much do they eat? And they were, eating, I don't know, the normal volume of fluid or formula they should. We finally were able to get to the bottom that they were taking the concentrate and diluting it by double. So I haven't used concentrated formula in many years, but let's say if it's a 1-to-1 ratio, 1 ounce of concentrated formula to 1 ounce of water, they were doing it 1-to-2, diluting it. So therefore the child was not getting enough of the nutrition that they needed. Same thing with the ready to feed. I've seen people dilute that to make it go further. And the powdered, again, they need to be taught how you don't want to make it too concentrated. You don't want to make it too diluted. Good hand washing before any preparation of bottles and nipples. Washing with hot soapy water or dishwasher. Don't prepare more bottles that can be used in a 24-hour period. And if you do, you do prepare bottles ahead of time, they need to be refrigerated. With concentrated, you always want to wash off the cans before opening. Read labels. I can't stress that enough. The powder, out of all three types of formulas, is probably the least expensive out of those three, but it is a little bit more time consuming for the mixing. But no need for sterilization or boiling unless the water is unsafe. You never want to feed an infant cow's milk or evaporated milk before a year old. Infant is not able to digest this type of milk and actually can cause GI bleed. Feeding is typically every 3 to 4, where with breastfeeding is every 2 to 3. Warming of bottles of any kind. We never want to warm breast milk in a microwave, and we don't want to microwave bottle formula either, because what can happen, the heating can be uneven, and they'll have what we call hot spots within the bottle, and it can actually burn the throat of the baby. And we never want to prop a bottle, put the baby in the carrier or the car seat and prop the bottle with a pillow. They can choke and they can aspirate. With discharge teaching, of course, this begins on admission. It really actually starts at the beginning of pregnancy, right? What are moms and dads' plans about feeding? Diaper service, car seat, childbirth, parenting classes. Are they going to get the Hep B or are they not? Purple Cry film. This is a film they show at Scott and White that is also required to show some type, whether it's called Purple Cry or it has another name to it, about shaking baby syndrome. We need to identify those families or young moms that need early intervention. So we need to closely observe and assess. Follow-up is usually in 2 to 6 weeks for moms. Encourage importance of keeping those appointments to assure that involution is occurring. Discuss how they're coping with having a baby at home and not sleeping and not having a normal routine. How is breastfeeding going? Hygiene, showering. One, it feels good, doesn't it? Okay. It gives mom a little time to herself to care for herself. Perineal care needs to continue till lochia stops. No douching, no tampons. Intercourse or sex can resume after bleeding or after the laceration or episiotomies are healed. But again, many times that natural lubrication does not return for 6 to 8 weeks. So they may need to use a water-soluble lubricant and also use protection of some kind to prevent pregnancy. Diet and exercise, a well-balanced diet, of course. Moderate exercise, walking is the best. It helps them to heal. High fiber foods, water, no dieting, of course. And I've already said ambulation or walking is the best. Danger signs. If we educate moms the right way, then they know what to expect. So we want them to report if they develop a fever of 38 degrees Celsius or 100.4 degrees Fahrenheit, persistent bleeding or a change in the bleeding pattern. Like I mentioned earlier, it's 14 days out, their lochia is lochia alba, and all of a sudden it turns back to lochia rubra. Prolonged after pains, signs and symptoms of a urinary tract infection, pain, redness, tenderness in the calves, redness or tenderness in the breast, abnormal foul discharge or pain, redness around the incision, episiotomy, lacerations, or any feelings of depression that persist. Newborn and follow-up care, typically, many facilities has initiated 36 to 48 hours. The newborn is brought back just to do a weight check and see how mom is doing and see if they have any questions and see if we can assist them in any way. Then usually with their pediatrician around 2 weeks and then around 6 to 8 weeks for a well baby check. Important to emphasize the weight checks, the keeping them on the correct immunization schedule, nutrition, car seat safety, and if they haven't seen the video about shaking baby syndrome, to have that available like in the clinic area, and also education about heat stroke and not leaving the baby in a car. Not that any of us would, but that's one of those new regulatory things that we have to do now. But it is important, and we need to help moms and dads understand not to leave their babies in their car seats in the car by themselves. So this concludes Chapter 9. Have a great evening.